Well, thank you very much, Terry. It's my pleasure to be here for several reasons. It's my pleasure to be here. I've always been envious and in awe of what Terry's been able to develop with the foundation here and with all your support. And just looking around the room and seeing the numbers that are here and the number of people that I've met, it's very gratifying. It's inspirational for me as a physician who treats ALS patients. But I'm also especially happy to be here to tell you about what's going on in the field, because without exaggeration, I can tell you that this is probably one of the most exciting times ever for the history of motor neuron disease and ALS. And I'll explain to you a little bit why I'm so enthusiastic about it, and give you some insights into what some of the developments are, but even more importantly, what some of our challenges are. So I call this talk Sorting Apples and Oranges, and there are many reasons why this is the most exciting time that I can ever recall in 25 years of working with motor neuron disease patients and being an active researcher. We probably have the best tools now to study the disease than we have ever had. Tools in the lab especially, to find new drugs, to find new targets. We're evolving some tools in the clinic that we've never used before, and there's just a sense of optimism amongst the investigative community that we're onto something. So that's the good news. We've had the best tools. We've collected more data than ever before. I mean, it truly is the kind of thing where you're away from the office on a vacation, you know you've missed something, because there's constantly new articles coming out, new discoveries, new genes, new proteins. The rate of discovery is unprecedented currently. But this is also arguably the most confusing time I can ever remember being a neurologist studying motor neuron disease and ALS. So it's a real paradox. We have the most exciting time and the most confusing time. And because of that confusion, we are very uncertain about some of the foundations of understanding that were established long ago. So it is very interesting. It's probably the most interesting time combined because it's exciting, confusing, and uncertain. We're not sure anymore if ALS is one disease. That used to be an opinion held by some, but now it's an opinion held by many. And if this disease, which we call ALS, is actually more than one thing, then we're studying it very incorrectly. And in fact, that might be one of the reasons why we've had trouble coming up with home run treatments for ALS. To use the baseball analogy, we have several base hits, but we don't have a home run. And it could be because of this. There may be no difference between inherited ALS and sporadic ALS, and that's something that has not been generally understood for a while, and I'm going to show you some examples of that. But that would be a major game changer if that turns out to be proven, more than it already is. And it's increasingly relevant to understand that what happens in a patient with motor neuron disease is not one thing. There are many ways for motor neurons to die, and it could be that there are different mechanisms operative at the same time, or perhaps at the different stages of motor neuron degeneration, there are different mechanisms causing the motor nerve cells to die. And if that's the case, any one drug that we use will never work effectively. Because unless we combine drugs for the early stage, the middle stage, the late stage of degeneration, we are never going to get on top of this. But that's something that we have not embraced as a community up until very recently. And that contributes to the sense of excitement I started out with. So I would say that we are currently facing, and this is my opinion, not that of the organizing committee, as they say, but I would say that we are currently facing the most important issue that we have ever had in the field. And it was one that I alluded to earlier. And that is, if ALS is not one disease, and ALS is more than one disease, we ought to figure that out first. Because if you study apples and oranges at the same time, and the fertilizer only affects citrus, the apples are not going to respond. And statistically, it'll be a wash. We may have been making this very error that's so easy to explain with apples and oranges. We may have been making this error for upwards of 30 or more years. Because for 30 or more years, we thought we were studying fruit, apples, oranges, and peaches. But if they're not all the same and they don't respond to the same medicines, then we've got to rethink as a community. We've got to rethink how we do our clinical trials, how we pick our drugs. The key to understanding the apples, the oranges, the peaches, the pears, is to understand the concept of what we call heterogeneity. Now, heterogeneity means that things aren't all the same. Heterogeneity is applied not just in science, but in life, there's heterogeneity. But in the area of medicine, and specifically in ALS, there is heterogeneity at every turn of this disease, clinically. In fact, you guys just have to look around the room, and those of you who are dealing with the diagnosis of ALS, motor neuron disease, you know you don't all deal with the same issues. Some have bulbar, speech, swallowing, and breathing issues. Some have weakness in their arms, their legs. Some just have rigidity and spasticity and very little muscle wasting. Some patients will go on fighting this disease 20 plus years. I follow several patients who are 15 to 20 years out and still going, while others progress much more quickly. Clinically, this is a very, very heterogeneous condition. Well, genetics, and I'll get into this more in a minute, that's been our savior, because in medicine we often think, if only we could find the gene. If we could find the gene, we would understand the disease, and if we could understand the disease, we could treat the disease. Well, we have found more than our share of diseases, more than our share of genes in this disease. We're finding genes every month that are what we call risk genes, sometimes causative genes. So why aren't we further along? Well, I'm going to explain that. It's because even the genetics, our silver bullet, even the genetics is heterogeneous. The imaging studies have been heterogeneous. Our biomarker studies have been heterogeneous. So my contention, and one of the takeaway messages here, is we've got to look at this disease as a research community differently than we have for the past ever. So the take-home messages, from what I'm going to tell you in a short time, is that we need to change the way we're thinking. That's the take-home message. And recent advances suggest that the less traditional way of thinking may be the better way. And I'll talk about that with regard to some recent clinical trials. And also, if we continue on the same path, and again, this is my opinion from lots of years of thinking about this, if we continue on the same path, we're making a huge mistake. We've got to be much more specific. We've got to hone down on some of the details of this heterogeneity. And mostly, we don't have the luxury of not paying attention to this anymore. If we had 5 drugs, all which were highly effective, we wouldn't be having this conversation. But because we don't, we are. So to understand this apples and oranges thing a little better, it's reasonable to say, and most investigators, even the naysayers, would agree, that if there are multiple different triggers of ALS, and those different triggers, meaning what starts the process of motor neuron degeneration, if those different triggers were caused by different mechanisms, we could treat the different triggers. We could have 6 different drugs, 6 different triggers. Or we could treat the final common pathway. Well, most of the clinical trials we've done for the last 30 years have said we don't care why the cell starts to die, but if we could treat the final common pathway, maybe we could save the cell from degenerating, from dying. The problem with that thinking is by the time it gets to the final common pathway, the horse is out of the barn. It may be too late. So we've got to pay attention upstream. So again, apples, oranges, and peaches. I'm from California, so it's a very agricultural reference, you know. In fact, where I used to live in California, it was intensely agricultural, and I had really good slides of fruit because there was a lot of fruit. So this is the ones I could find for this talk. So if there's apples, oranges, and peaches, and we're paying attention to downstream events, we're going to miss the opportunity to save the various forms of the disease. Now, clinically, we all know in neurology, you know how to make a diagnosis of ALS. A patient has what we call upper motor neuron signs, rigidity, spasticity, lower motor neuron signs, wasting, low reflexes, a weakness, and it's usually progressive. And when we see the combination of upper motor signs, lower motor signs, and progression, we say that's ALS. And the overlap between those three circles, as I said, is up until recently has been thought of as one disease. But in fact, if each of these various patients, and these are all people that I've had the benefit of knowing, one person, I don't have a pointer so I can't tell you, one person speaks, breathes fine, arms don't move. Another person, legs don't move, but his arms are fine. Another person just has bulbar. There's a person on the screen who's been dealing with the disease for 15 plus years. There's a person on the screen that just has a frontal temporal dementia syndrome with minimal weakness. All of these patients got the same diagnosis. All of these patients were told they had ALS. All of these patients could enroll in a clinical trial, the same clinical trial. In fact, it's a lot more complicated. There are a spectrum of upper motor neuron diseases and syndromes, a spectrum of lower motor neuron disease syndromes, and if we add to that some of our patients have frontal temporal dementia, but others don't have frontal temporal dementia, where does that fit in? So now should we be thinking that those that have this behavioral component and cognitive component have a different subset of the disease? What about the symmetry? What about the folks that have motor neuron symptoms mostly on one side or one part of their body? Is that a separate entity? What about the fact that some have bulbar symptoms? So the point of the slide is to show you that this is a very heterogeneous condition. Does that make a difference? It makes a huge difference. Survival is markedly impacted in these different presentations. Okay, I'm getting a new computer. That settles it. Survival is very impacted by these different presentations, meaning the rate of the motor neuron decline, the extent of the motor neuron decline. These are hugely important topics, important issues. And there have been attempts over the years for people to subset the disease. This was a publication from 2000, 18 years ago. A very well-respected neurology researcher from the UK published this. I guarantee you, in my 25 plus years practicing, we've never made the diagnosis of sporadic ALS type 1E. It was a great proposal. It didn't catch any traction. We didn't use it. Another has been various recognition of various ALS subtypes by name. But it's not caught on. And we're still very much trapped in the understanding of is this the disease or isn't this the disease? And in fact, even in my own center, my own people, they give me a hard time. You told them they didn't have straightforward ALS, and as a result of that, they don't believe they have any disease. You should just tell them all they have ALS if they have any motor neuron disease. That's the problem. So it's complicated, and understandably complicated for you as a patient community and as a caregiver community in the room. I'm sure it's very complicated to hear that maybe not all ALS is the same thing. It doesn't say it's not ALS, but perhaps we need to subdivide. It's not unusual to subdivide a disease. In fact, most every disease in neurology is subdivided. For example, MS. A person doesn't get a diagnosis of multiple sclerosis today. Today, they get a diagnosis of relapsing remitting MS, or primary progressive MS, or secondary progressive MS, or NMO disease. All of these are subtypes of multiple sclerosis. Now, when a drug comes on the market, no company tests it in every MS patient. They test it in the type of MS patient. Epilepsy is a better example. Complex partial epilepsy is not the same thing as focal or partial epilepsy. Not the same thing as all the different subtypes have different medications and probably different mechanisms. Now, what I think is fascinating is we develop drugs for these subtypes in both MS. Let's start again. Yeah. We develop, wow. Okay, now you can hear me. We developed drugs for these subtypes before we understand what causes these subtypes. How is it that our thinking in this field, and I'm being critical of myself here, how is it that our thinking has been so constipated, if you will, in terms of not opening up the door to these other ideas. This is a publication that just supports the fact that patients with different types of MS progress very differently. And I'm telling you that there's different medications for different types of MS. So let's move ahead in the interest of time away from the clinical heterogeneity and talk about genetic heterogeneity. Because as I mentioned, the gene is usually the silver bullet in the gun. And this was the case in the early 90s when the gene superoxide dismutase was identified in a selected group of families where ALS was prevalent. We thought, home run around the corner. I was there. I was at the meetings when we talked about it. It was a sense of excitement, unbelievable. All we need to do is fix the SOD problem, and the patients would get better. But it wasn't nearly that simple. It wasn't simple for many reasons, not only which that SOD by itself didn't seem to cause the disease like we saw in the patient, but clinical and genetic heterogeneity together became very much more evident as we're studying more genes. So this is a fascinating graph that I'm sure I won't have time to fully explain, but each of the letter designations going up the graph is a different gene that was discovered with the timeline at the bottom. And the size of the circle gives you a relative idea of how many, what proportion of patients might carry that gene. Bigger circle, higher percentage of the population might have that gene. But more importantly, in fact, shockingly, the color, the blue part of the circle means how often we see it in sporadic patients, patients without a family history. And the red part of the circle is how often we see it in families where the gene runs. Now, at first pass, you may not understand why that's so exciting. Because every one of these circles that presumably runs in families also runs in sporadic patients. Now, if you take away the distinction between inherited ALS and sporadic ALS, that's one of the foundations that we've based a whole lot of research that is different. These genes that run in families are causing a different kind of syndrome. They may be just as prevalent in certain mutations, meaning maybe these genes are giving us a more important clue to the mechanism of motor neuron degeneration. The other thing that comes away from all of these genetic discoveries is the fact that there are certain particular mechanisms, in fact, 3 particular mechanisms: protein homeostasis, RNA binding, and cytoskeletal. Words that probably don't mean very much to you, but they're essentially saying that there's overlap in the mechanisms, that there are a selected number of mechanisms that are implicated by many, many genes. So I'm going to skip this in the interest of time, and I'm going to talk to you about why understanding the gene alone is not the answer. It's a very important clue. It led to us focusing on some of these mechanisms that I think will be producing very effective therapies. But these 4 concepts, heterogeneity, pleiotropy, epigenetics, and gene interactions, are very important. So it's hard, and especially in a very quick way, like I only have the few minutes I have today, to explain to you all of these things with their complicated implications. So to make this fun, I use a little Hollywood analogy here. Genetic heterogeneity is when 2 people look alike, but they have different genes. So Katy Perry looks like Zooey Deschanel, right? But they're not the same person. So that happens all the time, that we see we see patients that look the same, and they have very different genetic problems. And what does that mean? That either means those genetic problems don't cause that disease, or those genetic problems cause multiple kinds of diseases. And that's genetic heterogeneity. Genetic pleiotropy is the opposite. That's when one gene causes many phenotypes, many different roles that she's acted in. And all of those different characters looked and sounded and acted very differently. We have many, many examples of ALS genes that really look like they cause motor neuron degeneration, but in different people, they're caused causing different kinds of syndromes. So that's a question right now. We're very excited about all the genetic studies that we have, but not exactly sure what role to ascribe to any one particular gene. Now, epigenetics, that's the third source of heterogeneity in genetic understanding. And epigenetics looks like this. You take a movie star and a bodybuilder from California, and you expose him to the State House, and he becomes the governor. Now, he wasn't the governor before he got exposed to the State House. The implication here is that the gene responds differently when it's in a different environment. So in different people that might be exposed to different environmental toxins, that might be exposed to other genetic abnormalities, the background that the gene is expressed in may result in why some of these diseases look as different as they do. Now, epigenetics is hugely important because we have lots of examples of areas of motor neuron disease where there seems to be a higher than expected number of patients. And it could be that something in the environment is interacting with something in the genome causing these epigenetic triggers for disease. The last one of these complicated things is gene-gene interactions. Now that means that the two genes together behave differently than either one did alone before they got together. Okay? I like Tony Bennett and Lady Gaga. That's my best example of a gene-gene interaction. Because Tony Bennett didn't sound anything like he did before he met Lady Gaga. But as you can see, the idea is that understanding the gene may not be enough. You have to understand the environment. You have to understand the other genes that might be abnormal. And that's why this is the most exciting and the most confusing time of all, because we're not exactly sure when we see a new gene discovery what it means. We're past the stage of thinking that a gene is going to explain this disease. We're way past that stage. Now we're just trying to figure out how many diseases there are, and could the pattern of genetic abnormality expression account for at least some subsets of the population. So I'm flipping through some of these data talks in the interest of time, but just to summarize that the heterogeneity in the clinic and the heterogeneity in the DNA is enough. But it's not all, because we have biochemical heterogeneity, meaning the biomarkers that some of you may be involved in clinical trials where you're giving up a sample of spinal fluid or a sample of skin or a sample from the blood. We're looking for markers that tell us you have one type of disease or another type of disease. That too is very heterogeneous. And the part of the reason is, as I mentioned earlier, there are different mechanisms of gene expression. There's different mechanisms. Some of the genes affect RNA metabolism. Some might affect the neuromuscular junction. Some might affect cell death directly. Some might affect inflammation. So what marker you take at what stage of the disease also becomes very critical. There are many, many markers that look promising. Some markers look promising because they increase the level as the person becomes more severe. Some markers look promising because they're present early on in the disease. But the takeaway message is we need better biomarkers, and we need to correlate what we're finding in the samples with what we're understanding about the differences in how one disease form is different than the other disease form. So I'm going to talk very briefly, because I do definitely want to leave time for your questions before we close, if you have any questions. But I'm going to talk briefly about one attempt that we're making to try to sort through some of this heterogeneous presentation. And that is a different way of looking at the old problem of how do we make a diagnosis. Rather than just saying there's upper motor disease, lower motor disease, bulbar disease, and sometimes cognitive involvement, we're grading every patient we see on a scale, an A, B, C, D scale. A means there's no involvement clinically from that that particular area. B would mean that there's some involvement, but it's not exactly affecting the patient very much. C is definite disability, and D is significant loss of function. So now every patient we see is no longer ALS or not ALS. They're ACBD or BCAA or whatever combination. So we take the same mixed patient bag that I showed you before, and we attribute a 4-letter label to every patient, which describes the kind of motor neuron disease that they have. And after that, we follow them over time to say, if you present with AACA, are you more likely to develop BB, how are you going to progress? So if you can envision every patient being graphed on that 3-dimensional graph, what happens over time? That, I think, may give us a clue to where the disease subtypes are clinically. Because if there's a certain disease subtype that's has more of a predilection to staying in that disease subtype, that may be a different mechanism than those that migrate to look the same over time. And that's looking very promising. So we have, for example, now I've done it so long that just looking at the 4 letters, I know exactly what the person's going to look like. A person with just frontal temporal dementia and severe ALS is going to have Ds all the way across. Whereas a person with ALS and no frontal temporal dementia, they'll have affecting all of the other areas, but not the cognitive area. So the letters become a little more descriptive than just the yes-no ALS type. And what we've done, and which we'll talk more about if it comes up in the questioning, is we've taken samples from every subtype of patients that we've identified, taken their skin cells and grown them up in the lab to develop motor neurons in the lab. And we say, do the motor neurons from this patient of this subtype look any different than the motor neurons to this subtype? And more specifically, if we stress or injure those motor neurons, do they all respond the same? Do they respond differently to potential therapies? So it's a very exciting area, and there's a company called Proceta, which I was going to show you some data on, but they actually are developing some drugs, and so far it appears as if some of their drugs may be selectively responsive to some of our patient subtypes. And their drugs affect what we call protein aggregation. So protein aggregation is hugely important, which I'm going to flip through, to stop disease progression by causing proteins not to clump together that seems to be driving some of the motor neuron degeneration. So if it turns out that this subtype demonstration, working with this small biotech company in California, turns out to be profitable in terms of a new drug target, that'll be a major change in our thinking, because we didn't study disease subtypes before, as important as I think that they are. There's a very well-known book called The Structure of Scientific Revolution, and it's written by Thomas McCune, who's a scientific philosopher. He's not an ALS doctor. He's not even a neurologist, but he's a philosopher. And what he talks about in this book is the way thought, how we think, how scientists think, and how things change over time. And what Thomas Kuhn says is science is made up with paradigms, things that we all accept, and we base our conclusions based upon paradigms. And normal science progresses by building on the paradigms. We have a lot of those paradigms in ALS. We think ALS up until now perhaps is one disease. We think upper motor neuron and lower motor neurons might be affected by the same pathology. But over time, things happen. Things happen that don't fit the paradigms. They're anomalies. Things like the ALS patient that lives 20 years, the ALS patient that has no weakness but only bulbar involvement. And those anomalies accumulate over time. And what Thomas Kuhn says is when you accumulate enough anomalies, you can't accept the paradigm anymore, and you enter into what he calls scientific revolution. That is, everything is up in the air. We say, oh, let's rearrange all the pieces to the puzzle again. We got the wrong way, and let's go a different way. I would suggest that where we are right now in the understanding of ALS is we are on the verge of what Thomas Kuhn would call the scientific revolution. And that scientific revolution is what I believe will give us the answer, hopefully. Because as we rearrange these anomalies to fit better, and perhaps no longer Is it going to be ALS as one disease? Maybe it'll be ALS type 1, type 2, type A, type B. And that's what I mean by sorting the apples and the oranges. Because if we don't sort the apples and oranges, we're going to continue to be, oh, it didn't pick it up. We're going to continue to be studying the same disease inappropriately. I want to conclude here, if I could get the, oh, good. So as I mentioned, the paradigm shifts come with these anomalies, and the revolution comes forward. So looking forward, what's happening today? I don't want you to walk away here thinking nothing is going on today. The increasing recognition of disease not being one type, not all being the same, has led to trials where we enroll based upon what's called cohort enrichment. We say you can only come in the trial if you have this particular abnormality in your spinal fluid. And the reason we do that is because, and this is for the first time in years, this isn't the first year I've been talking about this, but this is the first 2 years that I've seen actually movement in this direction. Because we're thinking that if you have that marker, you have that mechanism as a problem. And if you don't have that marker, the drug may not help you. And as much as we want to help you, we don't want to use that drug to help you. So the idea of personalizing more the therapy with the patient is something that I have not seen in 25 years. And I think we are on the verge of seeing that. So cohort enrichment, stratifying our trials to allow for patients with certain disease subtypes to be studied differently and separately from patients with other disease subtypes, very important. So just to summarize, and then I would like to open this up and see if you have any questions about what I said or about research in general today. I really believe, and I think Dr. Hyman Patterson would agree, this is probably the most exciting and confusing time of ever. I'd say in the last 10 years, but I don't remember a time when it has been so exciting because we have so many great tools. We have so much data. We have so much possibility. But we need to rearrange the puzzle pieces. We need to say there's a reason why good ideas of the past 25 years have not resulted in home run therapies. We have good therapies. We don't have great therapies. We need great therapies. I think looking at the pieces in a different way will lead us to much greater therapies. So again, it is time for a dramatic change. The recent advances have suggested we're in the right direction. We just have to keep going. And we don't have the luxury of ignoring the issue any longer. So I want to thank you very much, and I very much for your attention, for inviting me. It's been wonderful to be back in Philadelphia. I didn't mention this earlier, but I started my neurology career in Philadelphia. I was a resident in neurology at Penn. I started my family in Philadelphia, so we had a lot of good memories here, and it's been a pleasure to be back and certainly to see all of you here today, and I certainly welcome the opportunity for any of your questions. Thank you very much.